Okay, so yes, my role at Guy's and St Thomas's Critical Care is teaching and supporting the staff. As has been mentioned, as I'm sure those of you who work in critical care are aware, renal replacement therapy there tends to be quite nurse managed, and it's very much part of the nurse's role at the bedside to run these machines. This is going to overlap a bit with the previous speakers, so I'm sorry about that, but I think it's quite important when you look at the machine to kind of know some of the features that are special to continuous renal replacement therapy and how that differs to intermittent hemodialysis. So quickly going through, because continuous renal replacement therapy is a technique that was developed really in the 1980s, and it was taken up enthusiastically really by critical care clinicians as an alternative to what was available before, which was short, sharp, intermittent hemodialysis or peritoneal dialysis, which I won't go into, but has problems really for critically ill patients. It's not entirely satisfactory. Anyway, just looking at intermittent hemodialysis, pros and cons. It's a short, sharp treatment, traditionally 4 hours daily or on alternate days. The machines are designed to use online dialysis fluid from so there needs to be an ultra-purification plant. The advantages of intermittent are that it's less labour intensive in that it's a 4-hour session, so the nurse is busy with that machine just for 4 hours a day, rather than having to keep an eye on the machine 20. I am going to switch this off, I'm sorry, because I think I'll just really waste time. So the fluid is much cheaper once you have paid for the installation of the water plant, which is obviously a disadvantage, so that's a big upfront expense. Pure machines are needed because one machine can be used for several patients in one day. The dialysis fluid can be tailored to the patient's needs, the addition of electrolytes and so on to the online water. There can be tailored prescriptions, and because it's a short, sharp technique, the anticoagulation is used for a shorter time, if at all. Sometimes you can manage without. So against that, there's the fact, as has been mentioned, that fluids taken off over this short time, the day's fluid removal requirements taken off in 4 hours, that may cause hypertension problems. It may mean that you can't really give the volume of nutrition, enteral or parenteral nutrition that you'd like to, because it means that so much has to be taken off in that 4-hour period. Traditionally, certainly in the UK, intensive care nurses aren't trained to use those dialysis machines, and when intermittent hemodialysis was used in critical care, it was always a matter of the dialysis unit nurses coming in and operating the machines. Whereas these machines somehow were made with the intention, perhaps simpler, but so they could be used by ICU staff who have lots of other machines to get to know. If you're doing it daily, you are definitely going to use one circuit a day, although the circuits and filtered dialysers that are used for chronic dialysis, because the volume of sales is much higher, they are quite a lot cheaper than the circuits that are made for these machines. There will be some blood loss every day at the end of the circuit, which every bit of blood will be washed back. If you choose to do continuous renal replacement therapy, which in principle is a 24-hour therapy, though the reality is that there are periods of downtime because of clotting or off-unit procedures. Some studies have shown average treatment times in something like 16 hours, not 24. So the advantages of doing it continuously are the business of fluid being removed gradually, and so no problem, shouldn't be any problem with giving full nutrition because you can keep pace with any fluid input that you need to give by giving an equal amount, taking an equal amount out. ICU staff are trained to operate these machines, so you don't need to depend on external departments. And all these machines have been designed to use bagged fluids, bags of physiologically balanced mixtures that mean that the machine can be taken to wherever you want, actually, in hospital. You're not dependent on having plumbed in from this. And if you're lucky with the anticoagulation, then the circuit could last several days. They are more labour intensive because if they're on all the time, then a nurse has to be keeping an eye on the machine all the time. one machine per patient, obviously. The bagged fluid is very expensive, mainly transport costs, and it's a one-size-fits-all business. And I'll have a slide later showing you typical fluid composition. And unless the patient's very coagulopathic, you're going to need some anticoagulation, and that will be 24 hours a day, so that's an issue. Then there are some hybrid therapies these days, so chronic machines can be slowed down. That was mentioned by Marlies. So that's a kind of either chronic machines can be slowed down, or these continuous machines can be speeded up. So you do a day's work in like an 8-hour period, faster dialysis or filtration rate, faster fluid removal, but not as fast as a 4-hour session. And so this has been adopted, especially in units that don't have continuous machines. I get the impression where they just have the chronic online machines that with more unstable patients, they slow down the session to make it better tolerated. And as has been mentioned, any intermittent system gives the patient more chance to mobilise. But you are using one circuit a day, and there is some blood loss. So these are the 3 machines that are on sale in the UK now, really, the main machines. We are using this one at the moment, so that's why I've got some PS. They're all more or less the same. They're offering the same choice of modalities, but there are some differences. None is perfect, and some good features in certain ones, not in the others. It does take a while to get used to one particular type of machine. It's quite unnerving for nurses who are used to one machine to go and have to use another. It takes a little while to get used to. This is the same picture as one that Molly's showed, and it was just to emphasise the amazing thing that we're trying to do of getting blood to pass through these capillary hollow fibres with a lumen just about 16 times that of a blood capillary, and hoping that they won't clot very quickly. These are the modes that are available on all these machines, these continuous renal replacement therapy machines. I won't really refer to stuff, perhaps by the way, but when we're truly needing renal support, rather than just some fluid removal in a kind of diuretic resistant edema type of situation, it's that one of those 3 that is being used. And the F commonly gets missed off on CVVH, often it's just CVVH, not CVVHF. And it's all venovenous now. In the original, in the early 80s, there were arteriovenous circuits, particularly in the very early days before blood pump was introduced into the circuit. It was an arteriovenous cannula, and the blood was circulating under the patient's own blood pressure. So very quickly, because I want to get on to the machine, but it is important to know about how the different modes work in terms of this circuit. So filtration, you've got the filtrate or effluent coming off because of hydrostatic pressure difference, and you will have replacement or substitution fluid which can be put back into the bloodstream after the filter, post-dilution or before the filter, and anticoagulation is usually coming in there before the filter. So, as has been said, Haemofiltration uses the technique of ultrafiltration with convective solute clearance. The water's coming out because of the hydrostatic pressure difference, which can be increased by the filtrate pump that can increase that pressure difference to pull off larger amounts than might come spontaneously. Solutes are just dragged over by the water by convection. You need high volumes of ultrafiltrate to ensure adequate clearance of waste products and metabolism, which is the way that goes on in the glomerulus. And whereas in the nephron you get the reabsorption of most of that fluid, in these artificial systems we have a replacement of the majority of that volume by this bagged replacement fluid, the bagged replacement fluid. And if net loss is required, which it usually is, then the replacement volume is less than the ultrafiltrate volume. So solute clearance depends on the ultrafiltration flow rate. We'll say ultrafiltration and filtration, those words are used interchangeably, which I think is a bit confusing. The sealing coefficient of the solute in question, which depends also on the kind of membrane and the cutoff, concentration of solute in the plasma water, and the concentration of solute in the replacement fluid. And just a point that when we talk about filtration rate and dose and so on, in fact, on all these machines, you don't actually program the filtration rate, you program the replacement or substitution fluid rate and the net fluid loss rate, the fluid, kind of water you want removed from the patient, and the machine adds the two together, and that's the rate at which the filtrate or effluent pump works to pull fluid over into the waste bag. And it's important also to note with this and with dialysis, continuous dialysis, that solute clearance can be achieved independently of changes in total body water. So it's just that sometimes, I've noticed that sometimes the doctors would want more water taken off the patient, think that maybe you need to go to higher filtration or dialysis rate as well. If you don't, you could have a very low filtration rate and just be taking a lot of water off. Or if the patient doesn't need much water taken off but needs a lot of solute clearance or correction of acidosis, you might have a high filtration or dialysis rate and not much water being taken off. The other thing in terminology is the word exchange, because this is a kind of exchange. You're taking filtrate off, you're giving replacement fluid instead, and that term also gets used just in a very general way, also for dialysis, if it's in dialysis mode, which isn't quite right. And in fact, the other thing is the term filter. So this item here is the same item, whichever modality you're in, whether it's dialysis, diafiltration or filtration, but people commonly refer to it as a filter. In fact, many people refer to the whole machine as a filter. If you're in filtration mode, you need to have the replacement fluid going in, and you've got a choice of whether it goes before or after. And just quickly going through, pre-dilution has the advantage of not causing hemoconcentration. So it's added before the filter and then removed as the blood goes through the filter. That's good from the point of view of circuit life, and possibly also helping prevent the build-up of protein there that decreases membrane efficiency. On the other hand, the plasma water is diluted, and so every litre of filtrate contains less, the concentration of solute, say urea, is less than it would have been if the blood hadn't been diluted just before it went through the filter, so your efficiency in that sense is reduced. A few slides on filtration fraction, because when you're using these machines, and especially if you're having trouble keeping the circuits going, hemoconcentration, which makes the blood more viscous and is more likely to cause clotting to occur, is an important factor, and it's something that the nurses operating machines should be aware of, and if they've had difficulty keeping circuits going, they should arrange things to try and get this figure down, to have less hemoconcentration. So what is the filtration fraction? The correct formula is this top one, and basically the post-dilution fluid replacement rate and the net fluid loss represent the volume of fluid that's taken out of the blood that's either only replaced after the filter or not replaced at all in the case of net fluid loss. And so that's the element that's hemoconcentrating the blood, that's the water that's removed. And how hemoconcentrated the blood becomes depends on the blood flow rate and essentially the plasma flow rate, which obviously is a matter of the hematocrit. So what proportion of the plasma water is being removed, really, is the point. So just giving this example of a machine that's got post-dilution rate set at 2 litres and a net fluid loss at 100, and the blood flow at 200, hematocrit of 0.3, this is the formula, and it comes to a 25% filtration fraction. In reality, that accurate thing of plasma flow rate isn't used, and we tend to refer to the equation with just blood flow, whole blood flow rate, and that is the equation that's used by the machines, and all these machines calculate that. You can see your filtration fraction, and so it's very good. You can, if you alter anything, you can immediately see the effect in terms of the filtration fraction. So with the same settings, but considering whole blood flow, it would come to a filtration fraction of 17.5%. So the advice, if you're doing a proper filtration fraction where you're considering the plasma, the proportion of plasma water that's being removed, then you're meant to keep it below 25%. If you're doing it on whole blood, it should be below 20% or less, so below 21%. So I just mentioned earlier that the blood speed makes a difference to heme concentration. Just with those same settings, but increasing the blood speed to 300 mils a minute, which is 18 litres an hour, then you see that the filtration fraction drops from 17.5 to 11.7. So that's just illustrating the effect of increasing blood speed that decreases the heme concentration. So, well, I've said that. So heme concentration, risk of filter clotting is reduced by keeping whole blood filtration fraction less than 20%. So pre-dilution, if you do any pre-dilution, it doesn't contribute to heme concentration, so it doesn't affect the filtration fraction. And if you're doing dialysis, the dialysis rate has no effect on heme concentration. The dialysis fluid just passes through the outer compartment and out. It doesn't take fluid from the blood. Only the net fluid loss does. So hemodialysis. In this case, the dialysis fluid is being pumped in to the one inlet in the outer compartment of the filter or dialyzer, and being pulled out by the yellow pump, correctly called effluent pump really when it's a dialysis system. And it is flowing in a counter-current direction compared with blood flow because that gives the best clearance. It's a diffusion technique, so solutes are cleared by diffusion and in accordance with the concentration gradient. So depending on the concentration gradient, we've got the current arrangement, and the greater the concentration gradient, the greater the clearance. So solute clearance in hemodialysis depends, as with Haemofiltration, on the differing concentration of the solutes in the dialysis fluid and plasma water. It also depends on the dialysis fluid flow rate, because if you're, for example, if you're thinking about clearing urea, you've got urea in the blood but not in the dialysis fluid. So the faster you bring in that urea-free dialysis fluid into the outer compartment and pass through and out to the waste bag, the lower you keep that low side. Although urea is passing into the dialysis fluid, it's not hanging around, so the low side keeps lower. And the blood flow rate brings that urea-rich blood into the dialyzer more quickly if you increase the blood flow rate, so that keeps the high side higher. The surface area of the filter makes a difference to clearance in dialysis, which it doesn't in Haemofiltration. There's more surface where diffusion can occur, and the size of the solute has a greater effect, so smaller solutes clear better than larger solutes in hemodialysis. But if you're comparing the clearance of small solutes between hemodialysis and certainly post-dilution Haemofiltration, it's really quite equivalent. Because mostly in the kind of settings we use, the dialysis fluid is saturated, so it's at has the same concentration of the solute as was in the plasma water. When you do water removal, and obviously most of the time our patients do need some water removal, the effluent pump runs at a higher rate than the dialysis pump. So if you didn't want any fluid removal, it would be an exact match, and the fluid would dialysis fluid would just be in the outer compartment and out again at the same rate, bringing solutes with it. But if you want net loss, the effluent pump pulls harder and takes an extra amount off, and that extra volume is actually filtrate, because it's plasma water pulled across, because it just creates the transmembrane pressure across. So in fact, even when we think we're doing pure CVVHD, we're actually doing CVVHD with a little f, because the net loss is filtrate or ultrafiltrate. And as with filtration, the solute clearance issues regarding solute clearance and getting improved solute clearance should be considered independently of taking more water off. And then you've got the compromise modality of Haemodiafiltration, where there's a bit of both things going on. And the replacement fluid for the filtration part of what you're doing can be put in before or after, or even a combination of both. If you've got with the Gambler prism plex, you can actually split your replacement fluid between pre and post here. You have to make a decision one or the other. The fluid, as I said, it's not tailored to the patient except for the potassium concentration, and you use the same fluid whatever mode you're in. So whether the fluid is being used as replacement fluid in exchange for the filtrate, or as a dialysis fluid, it is the same fluid. And as you see, the makeup is kind of physiologically balanced in terms of the sodium, calcium, magnesium, potassium. It depends on what the patient's serum potassium is at the time, which potassium concentration you use. Obviously, if the patient's hyperkalemic, you'd use a lower potassium concentration bag to encourage that clearance. There's a kind of normal amount of glucose, because glucose is cleared very readily, so that needs to be replaced. And there is 35 millimoles per litre of bicarbonate, because, which is obviously higher than normal, because these are patients whose kidneys aren't working well, they've got low bicarbonate, and so you need to bring that, normalise that bicarbonate. So in filtration, the fluid coming off has a low bicarbonate, it's plasma water that's being filtered off with low bicarbonate, you're replacing with this fluid with high bicarbonate. If you're in a dialysis mode, your low bicarbonate blood is going through the dialyzer, and you've got high bicarbonate dialysis fluid going the other way, so there's a back diffusion to correct that low bicarbonate. And nowadays, recently, fluid with phosphate in has started to be produced by the companies that make these machines in fluid. For a long time, I think they thought it wasn't possible to have a stable kind of mix, but that's now coming onto the scene, which is good, because otherwise, as you know, those of you who use these machines, topping up of phosphate is a daily necessity because it's readily cleared. So, okay, so the safety features of the CRRT machines. All machines have most of these features, basically. So one is you've got a pumped blood system, and obviously one of the big dangers is that air might be into the patient. So there's an essential feature of having the air detector and return line clamp, and a bubble trap, although on Prismflex it's not quite a normal bubble trap, but it kind of does need to get rid of that problem. But usually there's a bubble trap, so if air does get in and the air detector goes off, you can try and get rid of the air and the blood level back up. Degassing chamber is sometimes needed, it depends on the design of the machine, and it's basically the Aquarius machine, which is one of the other machines that I'm familiar with, there was a degassing chamber, and that was because the substitution, the replacement fluid was below, so it's hanging at the bottom, being pulled up by the pumps, and quite a long circuit because the heater was a coiled tube, so the fluid was going along a very long tube, so a lot of suction to bring the fluid up, plus it was warmed, and if the fluid is a bicarbonate-buffered fluid, that actually causes CO2 gas, carbon dioxide gas, to be pulled out of solution, and so it had to be got rid of, so there's a degassing chamber. On this model of machine, the fluid is on top, and so it comes down very easily, there's no real pull, it's heated quickly, and there's no degassing necessary. A blood leak detector is mandatory on all these machines, and so I'll show you where these things are. Is this probably right? Yeah. Just a little. Thank you. So on this machine, this is the main bubble trap in the return line. By the way, although all circuits now are vena-venous, I think all the machines I know, colour code their circuits so that red is away from the patient, the access limb, and blue is the return or venous limb. And the bubble traps on the, this big bubble traps on the return limb. That's the air detector. If air is detected, there's a loud alarm, the blood pump stops. The return line clamp goes on too for extra security. The blood leak monitor, blood leak detector is here. This is the effluent or filtrate pump, and this is pulling filtrate or effluent from the outer compartment here and into the waste. And obviously one possible danger, I've never seen it happen, it must be very, very unusual, is that these hollow fibres, the material splits, and if it did that, obviously then you'd be pulling whole blood into the waste, which wouldn't be great. So they're very sensitive, we detect the smallest amount of blood leak. What else? Pressure monitoring. Pressure monitoring, I'll talk about pressures a bit more, but that's a very important part of running these machines. The scales, these are here the scales for the clean fluid and the waste fluid here, but the arrangements differ according to the machines. And the scales are extremely sensitive, they're to 1 gram, the resolution, and so that's very important because the machine is trying to do what you've asked it to do in terms of the rates of the pumps, but the scales are being monitored, so it's constantly monitoring that the weight loss from the clean fluid scales and the gain on the waste fluid scale is matches what you've asked for. And heating system. The early machines, until the year 2000, kind of that generation of machine. The heating, well, there wasn't an integral heating system. And so obviously you're taking filtrate off, if you're in filtration mode, you're taking filtrate off at body temperature, replacing it by room temperature fluid. If you're in dialysis mode, you've got heat exchange as the blood goes through and the room temperature fluid goes through as a dialysis fluid. So people really got cold and had their helpers on, and it's very unpleasant unless they happen to be paraxial. So it's a very efficient kind of heat exchanging system. So all modern machines have some kind of system to prevent heat loss, and in this system, in these chambers here, the fluid is heated before it goes on to the treatment part. But one of the Prism Flex, instead of that, has kind of heated jackets for the blood lines to prevent heat loss and kind of keep the blood warm. So that's, yeah. And then after this, I'll just show on this machine. Thanks. So it's very difficult. I tried quite a lot to try and make a diagram that didn't look very, very busy, but it's quite difficult. This is to show the main features in a diagrammatic form. So you've got the patient here. The red is the blood going away from that, and I've just realised that should be blue coming up into the bubble trap. Anyway, it should be red before the filter and blue afterwards. So this is the blood circuit going back to the patient there. Okay, and I've just happened to choose CVVH pre-post just for this diagram. So what you've got is the pre-dilution and post-dilution replacement fluids here on scales, and the fluid is being pumped up from the bags, warmed if it's that kind of system, and here going into the bloodline before the filter, and the post-dilution going in afterwards. The anticoagulation, if you're using heparin or epoprostenol or something like that, where unless you're on patients on systemic heparin for other reasons, but if you're giving heparin just the circuit, then it's usually given here for the filter. The effluent is coming off, the filtrate or effluent is coming off here, the yellow going into the effluent or filtrate scale, which is this on this machine, and it's going through the blood leak detector there. On the blood line, you've got the air detector and the return line count. And you'll notice that there are 4 points of pressure measurement. So before the blood pump, between the patient and the blood pump, that's the access pressure, blood being pulled out of the patient's vein, and reflecting how difficult it is, the pressure on that. Before the filter, 2, 3 on the return line, and then the final pressure is on the filtrate line. So if I can just switch on, is it just the up top? Just quickly show you on this. So this is the blood pump. The red pump here is the blood pump, and this is the filtrate or effluent pump. The blood pump is pulling fluid in from the patient here. Anticoagulation would go in here, and then it goes along and into one end of the filter or dialyzer. I've set this up in, or Rex sets this up in dialysis mode. Coming out now is coloured blue. This is the return lid now, going along here through the bubble trap with the air detector here. This is an optical detector that detects when prime fluid, the clear saline that you prime with, has changed to blood, so it tells you when the circuit is virtually filled with blood and you can start treatment. And these are the pressure, 4 pressure transducer points. This is, in this case, the dialysis pump, taking fluid from here and coming into the outer compartment here, and the effluent pump is pulling off here. So the dialysis fluid flow is going in the opposite direction to the blood flow. This is the replacement fluid, which in this case, it's coming from this scale, and in this case, it's going through its heater, and then it's being added to the returning blood here, which is after the filter. This is set up in post-dilution CVVH DF. Any questions? It's only, I mean, it's difficult in a short session. Okay, so blood pump speed. What are the issues with blood pump speed? Well, we tend to aim for at least 200 mils a minute, which is 12 litres an hour. From non-citrate anticoagulation. With citrate, because it's a much better anticoagulant, you can have lower speeds often. You need higher blood pump speeds if you're trying to achieve high filtration rates to avoid the hemoconcentrations filtration of the post-dilution part and the reduced clearance of pre-dilution. That's helped if the blood speed's higher. And if you're in a dialysis mode, then increasing the blood speed can help increase the clearance. And just in general, a faster blood flow, unless you've got citrate anticoagulation, tends to reduce the risk of clotting. So you need optimal vascular access to achieve good blood flow. Just to say, this is kind of linking in with the dose lecture of Christopher's, this is to say that when we talk about renal replacement rate and renal replacement dose, when you've got this kind of variety of modalities that you can put the machine in, but basically they're considered equivalent, they're just all added together. So if you were in this HDF mode with post-dilution dialysis, we just add those two rates together as being the total RRT rate, and then the dose is weight corrected. Or if you're in pre and post CVVH, with the top two. So a bit about the pressures, because that's a key point. When you're running these machines, you have to keep an eye on the pressures, and the pressures can tell you how things are going, and whether the machine's having trouble doing what you want it to do. So access pressure is normally negative in a venous circuit because central venous blood doesn't come out at a very fast flow spontaneously. And if you want to go at 200 mils a minute, you're certainly going to have to pull the blood out. So it'll be negative pressure. Increased blood speed, the faster you set the blood pump, the more negative it will be automatically, just for that reason. But it will also be more negative if there is an increased resistance to getting that blood out and into the circuit. So anything that can help, can increase the resistance will make it more negative. So we'll come back to that one because it's linked to this return pressure. Return and pre-filter pressures, they're always positive. They're after the pump, so the blood is being pushed back now into the patient. And they will be more positive, first of all, if there's increased blood speed. If you're going faster against a constant resistance, then the pressure generated will be higher. But also more positive if there's increased resistance to the post-pump blood flow. So what causes this increased resistance? Well, on this side of things, clotting is a very important factor that will increase the resistance. And on the both of them, the blood flow thing is all to do with the quality of the access and the way it sits, the line sits in the vein, and whether there's any kinking because of patient movement or the anatomy of the patient. And although there's huge, and I should report this, dialysis catheter with me, the manufacturers make huge efforts to make catheters as kink resistant as possible, with the holes as kind of carefully designed as possible to avoid them being blocked, and the kind of shape of the lumen to avoid turbulence and things that can grow clotting. But that's where the problems can arise. Transmembrane pressure is the other thing that we note, and the transmembrane pressure is basically that pressure between the blood in the capillary and the outer compartment, and the machine's automatically calculated, and they're calculated as being halfway between the pre-filter pressure and the return pressure. The pre-filter pressure is always going to be that bit higher than the return pressure because the filter or dialyzer is a big resistance in the circuit, so it will always be more positive. Anyway, it takes the halfway point of being the pressure in the blood compartment, and then the difference between that and the filtrate pressure, which is the pressure in the filtrate, the effluent line here. And that will either be 0 or positive. If it's negative, it tends to mean the circuit's clotting. It will be more positive if you're trying to get more fluid over. Obviously, the yellow pump pulling harder will automatically. So if you're doing CVVH with big volumes of filtrate, rather than CVHD, where the only filtrate happening is the net loss, instantly from the start your TMP will start higher. And then as time goes on and the pores of the membrane of the fibres get clogged, then the yellow pump has more difficulty, has to pull harder, more negative pressure there, so the TMP will go up. If you don't in this, but if you use the low flux filter, I mean that's what flux is about, is how easily water goes across them. The low flux will immediately have a higher transmembrane pressure, and if you're clotting and the blood compartment pressure is higher, then the difference will be higher. So the alarms are set, and I'm sure those who work in intensive care will be familiar with the sounds of the alarms, which go off sometimes very, very frequently. They all have their limits, and basically the high limit is set on the access pressure to about -300, and the point is, when these alarms go off, the blood pump stops and the treatment stops. So the blood pump stops, there's no point carrying on pulling if the blood's not coming. It can damage the vein wall and also big negative pressures, the red cells can start to immunise. Return pressure, if you carry on against a high pressure, you might get blood leaks, so it's dangerous, plus you might push clot forward. How am I doing for time? Yeah, that's only a few minutes. So you can't carry on, there's no point in carrying on, the blood pump stops basically, it's dangerous, you could have an enormous leak of high pressure blood. The TMP is the risk of membrane rupture if you carry on pulling, there's a big pressure difference and blood loss into the waste. So as I said, when these alarms are triggered, the blood pump and the treatment pump stop, and so you've got static blood, so increased risk of clotting, and on top of that the treatment pumps are stopped, so there's no clearance going on at all. So it's not a happy situation. I should also say that they will also alarm and stop if they haven't hit the limits, but there's been a sudden significant change from what the pressures have been running at. So that can be just a gentle movement to the patient who can be enough to set that off. But the aim should always be to have a smooth run of the circuit. Because if there are no alarms, the machine is doing exactly what you've said. That's an important point to note. So exactly what you said would be done, and they are very, very precise, the way the machine works. The fluid loss will be exactly what you asked for. But if you find that gradually, and that's why you should look at trends in pressure, if the access pressure is increasingly negative, or the pre-filter return or TMP pressures are getting increasingly positive, then you should take note, because it shows the machine is having difficulty doing what you've asked it to do. And as I said before, little movements can cause the pressures to jump, but also if they're already quite near the limit, it's more likely that they'll hit the limit and stop. So good access and effective anticoagulation is absolutely critical. It's really the be-all and end-all. This is the last slide. But it's a very important slide. So if you're thinking, how do we run CRRT effectively? Well, there's got to be good training and support for staff. It really does take quite a long time. I suggest 6 months when people start to feel reasonably comfortable. And even then, troubleshooting, you just have to have the hours of contact and see different things happen. But I hope that the nurses understand the principles of what's going on.